संगीत तुझसे हर शब्द तेरा हर गीत तुझसे इशार देवा अज्ञानता से.
We are in India, in the city of Varanasi, where the sun rises around 5:30 over the Ganges River.
This is really early for us, but by this time health workers have been up for hours.
Here they are arriving at the hospital to prepare everything they need for the day's measles catch-up campaign.
This is a vaccine carrier. It's incredibly hot here and there's very little electricity. Today is 105 degrees. Each carrier has to have 4 ice packs to keep the vaccine cold. The carrier holds 20 vials, and each vial can vaccinate 5 kids.
This campaign hopes to reach 134 million children across India.
630,000 of those are here in Varanasi.
The health workers load the vaccine carriers and themselves into auto rickshaws and disperse to different communities.
This is happening simultaneously all across this vast area.
Community mobilizers work hard in the days and weeks before the campaign to make sure parents know when and where to bring their kids.
They tell them how important it is to vaccinate against measles and how 2 doses can protect a child for life.
The children's pinky fingers are dyed purple, so it's easy to tell who has received the vaccine.
The sheer number of children in India is absolutely staggering. We met just a tiny bunch of them, but we couldn't help feeling that every child we saw vaccinated would have a better chance at life.
A chance children everywhere deserve.
It was just incredible to see the campaign in person, but you don't have to travel to India to make a difference in a child's life.
I'm Dr. Phoebe Thorpe, and it's really my pleasure to welcome you to the June 2016 Public Health Grand Rounds, working to eliminate measles around the globe. First, a few housekeeping slides. We have continuing education credits available for nurses, physicians, pharmacists, veterinarians, and a whole bunch of other folks. Please check our website for additional information. We also are available on social media, and we have a featured video segment called Beyond the Data that you can check out. It'll be posted by the end of this week. Thank you. Also, we are tweeting today, so please use CDC Global, at CDC Global today, and CDC Grand Rounds for all your tweeting needs. I'd also like to give a nod to the polio STOP group and the STOP MR group, who are in Auditorium B joining us. We have also partnered with the CDC Public Health Library to feature scientific articles related to measles elimination, and you can find them at cdc.gov/library/sciclips. Here is a preview of the upcoming Public Health Grand Round sessions. You'll note that there are 2 in September. Please join us. And in addition to today's featured speakers, I'd like to take a moment to acknowledge the important contributions of those listed below. Thank you very much. And now, a few words from CDC's director, Dr. Frieden.
Good afternoon, everyone, and welcome to those here. Also welcome to our visitors from the STOP program, Stop Transmission of Polio. We have 53 participants from more than 20 countries who will be going on assignments to more than 25 countries. We're delighted to have you here, along with staff from UNICEF, WHO, and the Bill and Melinda Gates Foundation. When I joined EIS in 1990, my very first outbreak investigation was of measles. And 3 strong impressions left me from that outbreak investigation. The first was how incredibly infectious measles was. Most likely the single most infectious disease that we know in public health. Second was the likelihood that healthcare facilities were serving as amplification points for measles in emergency departments, doctors' offices, and elsewhere. And third, how important it was to increase vaccination rates in a large group of society in order to protect other people, particularly infants under the age of 1. And this is important not only within societies, but between societies. And we've seen that in this country as measles outbreaks in the Philippines and elsewhere have disseminated to other countries, including the US. Globally, though, although measles remains a constant potential threat here, it remains a deadly killer around the world, killing more than 145,000 people, mostly children, each year, and infecting more than 20 million people around the world each year. It's a serious disease. A couple of months ago, I got an email from a former staff person of mine from India who was then working in a remote village of Liberia. And as Ebola began ebbing, measles began surging, and she sent me a tragic picture of a young child who almost died from measles but was left blind as a result. So we continue to see devastating consequences of measles around the world. In the US, measles was declared eliminated in the year 2000, and as far as we know, we have not had endemic transmission of measles here, but every year there are cases from travelers and individuals who aren't vaccinated or who traveled here while infectious. We've had over the last decade about 60 cases a year, but starting in 2011, we had more than 200 cases, and in 2014, more than 600 cases. Recently, we had a large outbreak, as you may recall, associated with an amusement park in California. That is largely over, Amusement Park A. But fundamentally, measles shows both the potential and the pitfalls of disease control. Vaccination is critically important, not just to knock down cases, but also to protect people who can't be effectively vaccinated, particularly infants and individuals who are immunocompromised. It's important also to look at ways to simplify what we do. Continuous innovation is crucial for ongoing progress. As you'll hear today, CDC is collaborating with the Georgia Institute of Technology. They've been a terrific partner on the projects that we've done with them. And here, this is a microneedle patch that might just revolutionize the way we give measles and other vaccines. It would be put on like a Band-Aid. It would be potentially cold chain stable, meaning we don't need a cold chain. And if feasible, it would make it much easier to reach people. We don't know if it'll work, but we do know that continuous innovation is crucial for effective programs. And that's why I'd like to thank all of the partners who work on the Global Measles Rubella Elimination Project or program. It's not easy. The level of infectivity, the need to reach each community, the need to get very high rates of immunity and maintain them show the need not only of effective public health action, but of effective collaboration with health systems so that those high levels of vaccination can be achieved and maintained, and we can make measles elimination a reality around the world. Thank you all very much.
Thank you, Dr. Frieden. And now for our first speaker, Jim Goodson.
Good afternoon, and thanks a lot, Phoebe and Dr. Frieden, for the introduction. So measles is an RNA virus for which humans are the only reservoir. Measles virus survives only by airborne transmission of aerosolized respiratory secretions from person to person. After an incubation period of 7 to 21 days, clinical symptoms develop, accompanied by immunosuppression, which often leads to secondary bacterial infections and complications. Measles is one of the most highly contagious diseases, but is vaccine preventable. It typically occurs in childhood, and cases have a classic rash fever clinical presentation. Severe complications can occur and include pneumonia, diarrhea, encephalitis, and death. Between 0.1% and 10% of measles cases die. In 2000, the WHO ranked measles 5th among all causes of childhood deaths, and that was higher than HIV and malnutrition. As I mentioned, measles can be prevented by vaccination using a safe and effective vaccine that was licensed in 1963. The vaccine must be kept cold throughout all stages of shipping and storage to retain its potency, and high vaccination coverage can prevent outbreaks and interrupt transmission of the measles virus. WHO recommends that all children receive 2 doses of measles-containing vaccine. So since measles virus survives only in humans and transmission is easily prevented by vaccination, global measles eradication can be achieved through efforts similar to those used to eradicate smallpox and more recently polio. Smallpox eradication program integrated measles control efforts and also helped establish the Global Expanded Program on Immunizations, or EPI. Smallpox eradication was one of the greatest public health achievements of our time. And if it had not been eradicated, surely we'd still be battling outbreaks of smallpox today. In 1988, the World Health Assembly officially adopted the polio eradication goal, and WHO and partners established the Global Polio Eradication Initiative, or GPEI. GPEI partners have built an eradication infrastructure that included integration of measles elimination activities along the way. And now that polio is almost gone, legacy planning has started, including transitioning polio assets to measles and other public health priorities. So with measles eradication now on the horizon, let's review some of the key events that have led up to this point. In 1994, the Pan American Health Organization, or PAHO, set a goal for measles elimination in the region of the Americas. In 2001, the WHO, UNICEF, CDC, the UN Foundation, and the American Red Cross established the Measles Initiative, a partnership with a vision of a world without measles. In 2002, the last endemic case occurred in the region of the Americas. And in 2011, the World Health Assembly concluded that measles eradication can and should be done. In 2012, the World Health Assembly approved and the WHO published the Global Vaccine Action Plan, or GVAP, as part of the Decade of Vaccines, and we'll talk a little bit more about GVAP. The Decade of Vaccines was largely funded by the Bill and Melinda Gates Foundation, and the GVAP includes a goal for measles elimination in 5 of the 6 regions of the world by 2020. In 2013, the Southeast Asia region was the last region in the world to establish a measles elimination goal. So all 6 regions have an elimination goal with a target date of before or by 2020. There are 3 global measles control targets to be achieved by 2015, and we'll review these a little bit now. The first is routine first-dose measles vaccination coverage of at least 90% at the national level and at least 80% in every district, reported measles incidence of less than 5 cases per million, and measles mortality reduction of at least 95% compared to 2000 levels. In addition to those targets, the GVAP, as I mentioned, which is the key document guiding all global immunization efforts, set a goal to achieve measles and rubella elimination in at least 5 of the 6 WHO regions by 2020. Since strategies and goals for measles and rubella are integrated, and there's a combined measles-rubella vaccine that's safe and effective, global efforts will lead to eradication of both diseases, or elimination of both diseases. So how are we doing with the routine first dose of measles vaccine, which we call MCV1? So globally, MCV1 coverage, represented here by the blue bars in the graph, has increased over time, but you can see it has stagnated at about 84% for the past 5 years. So you can see there are 3 regions above the target line and three regions below the target line, the trend lines there. The Americas, European, and Western Pacific regions are all above the target of 90% measles coverage, and the African, Southeast Asia, and Eastern Mediterranean regions are still below the target of 90% MCV1 coverage. This map shows routine MCV1 coverage by country. You can see most countries are meeting the target of at least 90% coverage. However, there are still 65 countries in the world that still have MCV1 coverage less than 90%. You can see on the map that most of these countries are in Africa, Eastern Mediterranean, and the Southeast Asia region. Looking here a little closer at the Western Pacific region, you can see that, that after increase in measles vaccination coverage and following implementation of measles elimination efforts, incidence dropped to 5.9 in 2012. That was an historic low for the region. However, since that time, incidence increased in 2013 and again in 2014. And these recent increases can be attributed to outbreaks that occurred in 3 of the largest countries by population in the region: Vietnam, the Philippines, and China. Although the resurgence in China is ongoing, it's important to acknowledge that China is deeply committed to measles elimination, as they were with polio eradication efforts, and has achieved high routine vaccination coverage nationally. Additionally, China conducted its first nationwide measles campaign in 2010 that reached 100 million children. And following that campaign, outbreaks during the resurgence period generally have been smaller and with an age shift to include older age groups, indicating some progress toward elimination. Turning our attention to the Southeast Asia region, measles elimination efforts there have led to an increase in 2-dose coverage and in turn a decrease in reported cases in the region. Indonesia, which is represented in the middle portion of the stacked bars, and India, the bottom light blue portion of the stacked bars, the 2 largest countries by population in the region, account for half of reported measles cases in the region, and both are priority countries for focused elimination efforts. Global coverage of the routine second dose of measles vaccine, which we refer to as MCV2, was only 53% in 2013, and this is largely due to the fact that some countries haven't yet introduced a routine second dose. So to achieve measles elimination, high coverage with 2 doses of measles vaccine is needed, and this can be achieved either through routine immunizations or in some countries, a combined strategy of routine and mass vaccination campaigns, also called supplementary immunization activities or SIAs. Each year, 4 to 5 more countries introduce a routine second dose, and so the number of children protected is increasing globally. Because MCV2 is often given in the child's 2nd year of life in these countries, it's an important opportunity to provide children with other child health survival interventions, including catching up of missed vaccines in the EPI schedule. Measles vaccination campaigns are implemented each year, and in 2014, more than 200 million children were vaccinated during measles SIAs. Over 3/4 of these campaigns provided other child health interventions, including rubella vaccine, oral polio vaccine, vitamin A, deworming medications, and bed nets. Following measles elimination efforts, there's been an 87% decrease in global measles deaths since 1985, a 75% decrease in measles deaths since 2000. From 2000 to 2013, 15.6 million deaths, measles deaths, have been prevented. Nonetheless, we're not on track to meet the global 2015 target of a 95% reduction. As mentioned, polio eradication is nearly complete, and the elimination of polio in India in this decade was an enormous public health success. Today, children are no longer being paralyzed by polio, and mothers no longer live in fear of that disease. And now there's a high-level commitment in India for measles elimination, building on the polio eradication program. This map shows the existing polio reporting sites, including public and private hospitals, health centers, medical practitioners, and traditional healers that are now being used to implement measles surveillance, strengthen routine delivery of measles vaccine, and improve the quality of measles campaigns. Currently, India is planning a nationwide MR campaign targeting children under 15 That's a target age group of 450 million children who will be vaccinated during this campaign starting next year. And within 6 months after the campaign, 2 doses of MR will be introduced into the national routine immunization schedule. In addition to building on the existing global polio infrastructure, there's a wealth of experience and lessons learned from the polio eradication experience that are now being applied to measles and rubella efforts. Sustaining political leadership, motivation of field workers, ensuring management and accountability at all levels is critical. Sustaining the gains for improving routine EPI is an integral part of achieving elimination goals. For these global efforts, securing long-term, stable funding is critically needed. Engaging communities is key to reaching the underserved populations, as was done so successfully in countries for polio eradication. Integrating epidemiology and lab-based surveillance is critical for rapid case detection and response, and we must continue refining strategies through research and innovations. So I would like to acknowledge here all the partners of the Measles and Rubella Initiative, and now with polio ending, it's time to strengthen the partnerships and work together to achieve a world without measles. Thank you. Thank you, and so I'd like to introduce the next speaker, Paul Rhoda, measles team lead here at CDC. Paul.
Okay, good afternoon, everyone. As I'm sure you all know, high-quality surveillance really depends on careful collaboration between epidemiologists, public health workers, and the laboratory. So in the next few minutes, I'd like to give you an overview of the laboratory component of global surveillance for measles and rubella. And this surveillance is provided by the WHO Global Measles and Rubella Laboratory Network. This network was initiated 15 years ago. It's built on the successful model of the Global Polio Laboratory Network, which consists of a multi-tiered structure. There are 3 global specialized labs, 14 regional reference labs, or at least 2 labs in each of the WHO regions, which serve 161 national laboratories. And there are 586 subnational laboratories, including 362 subnational laboratories in China. So nearly half of the network, which is over 700 laboratories in total, is in China, where measles testing is conducted at the prefecture level. To assist in these efforts, we have 7 global regional laboratory coordinators. These are microbiologists that serve to coordinate lab activities within each of the regions. And we have a global coordinator at WHO headquarters in Geneva that oversees the coordination of the entire network. Some of the strengths of the lab network is that the lab network offers a standardized testing and reporting structure, and all of the labs have excellent quality control measures in place. The network generates timely results that help to drive public health decision-making in near real time. The laboratories that are a part of the network are under local management and control, and therefore are aligned with national public health priorities. And the laboratory network offers integrated testing to include other vaccine-preventable diseases, including measles and rubella, but in addition, some of the laboratories are testing for yellow fever, Japanese encephalitis. Some are beginning to test for rotavirus and hepatitis B, depending on the region and national priorities. This slide shows the major roles of the global lab network, and I'm going to expand on each of these roles in the next few slides. The first and most important role is to provide laboratory confirmation of suspected measles and rubella cases. So it's important to distinguish the C of febrile rash illnesses and confirm those febrile rash illnesses which are actually measles and rubella. And this is done by detection of measles or rubella-specific IgM in serum samples. This is done using commercial enzyme immunoassays. And now more and more of the labs are also initiating using molecular testing. So they're attempting to detect the viral RNA from measles or rubella by RT-PCR. This slide demonstrates the workload of the global network has increased steadily as more and more countries are moving toward accelerated control and elimination. So that in 2014, over 250,000 serum samples were tested for measles IgM in this network. So there's a significant amount of testing workload in this laboratory network. On the genetic characterization of viruses is the next major important role. And one of the essential criteria for verification of elimination is the documentation of lack of an endemic genotype of measles virus. And this can only be done by genetic characterization of the viruses. This genetic characterization also helps us to map transmission pathways of this virus, and this slide just shows a schematic of a very recent example of just how quickly measles can spread, and this documents spread of measles from the large outbreak that occurred in the Philippines about a year ago, and the red lines just indicate all of the countries where genotype B3 was detected. It's probably a lot more than that, but it was not enough room on the slide to put all of the lines in. There was also a second genotype that was circulating in the southern part of the Philippines, which is called genotype D9, which was imported into the state of Ohio last summer and caused a fairly large outbreak there. To help us to track the transmission pathways, we have a global sequence database. It's called MEANS. And just to let you know, there is a global sequence database for rubella, an analogous database, which is called RUBENS. The global database for measles is maintained at Public Health England by our colleagues at Public Health England. However, the governance is supplied by all of the labs from all of the WHO regions. There's a steering committee that has participation from every WHO region. Presently, there are over 22,000 sequences in the database, and these sequences are available to labs that participate in the global laboratory network. And initially, there was some resistance with these labs among the labs to sharing sequence data with a global database. I would say now that almost all of the laboratories are participating and the data are shared on a very timely basis. Within 2 months of detection and sequencing, the sequence data are there. However, we're always trying to discuss new ways to make the data, the sequence data, more accessible to people inside the network as well as individuals outside the network who may want to look at it. And this sequence data really gives us a way to rapidly analyze strains and see where they have been circulating. So I can take a sequence that I get from the US and put it into the database and find out everywhere that particular strain has been circulating. So it's very helpful. One of the ways that we want to make the data more accessible is prepare these maps which show the geographic distribution of measles genotypes, and these maps are distributed periodically by WHO. It's hard to miss the big green dot on China, so genotype H1, which is shown in green, is the endemic genotype in China. And my colleagues in China have done an extremely good job of genotyping viruses. That's why there are so many sequences from China. Unfortunately, there's still a lot of measles in China, so they have no problem finding viruses. In the rest of the world, we have genotypes B3, D4, D8, and D9 are the most frequently detected genotypes last year, and they're shown in various colors on the slide. And this slide also points out areas where virologic surveillance needs improvement, and you can see that there are very few sequence entries from the African region, particularly sub-Saharan Africa, so we clearly have some work to do to improve virologic surveillance in that part of the world. The final role of the laboratory is confirming vaccine coverage, and the laboratories are asked to perform seroprevalence studies to verify vaccine coverage. And again, as countries move toward elimination, the national verification committees are going to be asking for proof of vaccine coverage, and a lot of this is going to be derived from seroprevalence studies. Some of the challenges for the network. Financial sustainability is always a problem, as CDC is the only external sponsor for the network at this time. The expansion of surveillance in India will require expansion of lab capacity to support the surveillance. We want to stay new and introduce new methods, but new methods must be carefully evaluated and validated before they can be introduced into a routine testing scheme. Laboratory testing in an elimination setting puts additional pressure on the lab because the additional testing must be required to classify as many cases as possible. So even though there are fewer cases, The lab must work harder to get a classification on as many of those cases as possible. So the workload actually sometimes goes up a little bit as you move into elimination. And laboratory data are going to be reported as part of the national verification process. So the laboratory will have an increased workload in preparing reports for national verification committees and for regional verification committees so that they can evaluate their progress toward elimination. New technologies, we always want to keep current. New technologies on the horizon. We're working to improve serologic testing. The neutralization assay is a time-consuming assay. It takes a while to perform, so we'd like to develop neutralization assays that can be done a little bit faster. A neutralization test is very useful because it provides a serologic correlative protection. We're also working on high-throughput seroprevalence assays using various types of platforms. Our colleagues at the WHO have been active in point-of-care testing for measles to be able to do measles and rubella IgM detection, not in the laboratory, but in field situations with a small dipstick-type assay, and so those are under development at this time. There are, of course, new and improved molecular assays, and we're always trying to get as much information out of, to refine the amount of sequence information we can get so that we can do as good a job as possible to map the transmission pathways. And this will require getting additional sequence information from the different strain. So we're working on methods for whole genome sequencing and next generation sequencing, and part of that is being supported by the CDC Advanced Molecular Detection Initiative. So we have a project that does cover measles and rubella sequencing. And finally, vaccine development. The lab is involved in evaluating alternative methods to administer measles vaccines. And I think I'm happy for the introduction from Dr. Frieden and about the microneedle work that's being done in collaboration with CDC and Georgia Tech. So in conclusion, I would just like to acknowledge all of my colleagues in the Global Measles and Rubella Laboratory Network, as well as the members of the measles and rubella lab teams here at the CDC. And now I'd like to introduce our next speaker, Dr. Desiree Pasteur.
Thank you, Paul. Good afternoon. Thanks to CDC for the opportunity to participate in the public health grand rounds. My presentation will provide you an update of measles epidemiology in the Americas and the most critical challenges for sustaining the elimination gains. This graph summarizes the history of measles elimination in the Americas and the impact of vaccination strategies. In the pre-elimination era during the 60s, more than 600,000 measles cases were reported annually in the Americas. The bars represent measles and rubella cases, and the black line represents the vaccination coverage against measles and rubella. As you can see, as vaccination coverage goes up, the number of cases goes down. By the early 90s, several countries started vaccinating all children aged 9 months to 14 years through catch-up campaigns, a strategy recommended by PAHO aimed at interrupting endemic measles transmission. Later, follow-up campaigns were conducted to give children aged 1 to 5 years a second opportunity to be immunized against measles and rubella. Therefore, in 1994, a goal to eliminate measles from the Americas by 2000 was set for all countries. Since then, PAHO has established the main vaccination and surveillance strategies, and as a result, this region was the first one to achieve endemic measles elimination in 2002, the year when the last endemic outbreak was reported in Venezuela. In this chart, you can observe the trend of confirmed measles cases after interruption of endemic transmission between 2003 and 2015, with an annual average of 153 cases per year until 2010. However, large outbreaks in Canada, Brazil, Ecuador, and the United States resulted in an 8 to 12-fold increase in the number of cases reported in 2011 and in 2014, respectively. The highest rate of confirmed cases was reached in 2014, with 1.9 cases per million people, which still is lower than the rate of 5 per million people established as a milestone by the World Health Assembly in 2010. The following maps describe the geographic distribution of measles cases in 3 selected years in a scale of 1 measles case per dot. By the 21st epidemiological week of 2015, there are 515 confirmed measles cases in 5 countries: Brazil, Canada, Mexico, the United States, and Chile is the last country that has had a 5-case measles outbreak since May of this year. The first outbreak in the post-elimination era with more than 12 months of transmissions has occurred in Brazil, and by definition, Brazil has reestablished endemic measles transmission now. This measles outbreak started in 2013 and has more than 2 years of continuous transmission, which is being described by PAHO as drop-by-drop transmission with the same genotype D8 circulating in the states of Pernambuco and Ceará. The last case reported was on May 18 of this year, for a total of 1,047 measles cases in the overall outbreak until now. This is a brief summary of the main characteristic of the last measles outbreaks in our region. The United States and Canada have been facing multiple outbreaks with faster virus dispersion into and out of countries with different genotype measles viruses, but with a successful control of the total outbreaks. In the United States, more than 50% of the cases occur in people aged 5 to 39 years, and more than 80% were unvaccinated people. Main barriers to vaccination were philosophical or religious beliefs, or simply because the children were too young to be vaccinated. In Brazil, there was a slow and sustainable drop-by-drop transmission in 2 states with just 1 genotype, D8, but the control interventions weren't successful to stop the transmission until now. Most of the cases in one of the Brazilian states, Pernambuco, were in children less than 1 year, 48%, but in the second state, Ceará, children less than 5 years, adolescents, and young adults were the most affected groups. According to last Brazilian data, in the Ceará outbreak, 89% of cases were unvaccinated. And regarding the vaccinated cases, around 10% of the total cases had 1 dose of MMR vaccine, and around 1% of vaccinated cases had 2 doses. This demonstrates once again that 1 dose for interrupting measles is not enough. So now we are moving to the most critical challenges for sustaining the gains. During 2011 to 2015, there were more than 4,000 imported or import-related cases. That's the reason why countries in the Americas have to be prepared permanently for preventing measles virus spreading from imported cases, mainly in countries which organize massive gathering events like the FIFA's World Cup, tourism carnivals, massive religious concentrations, etc. For sustaining the elimination gains, PAHO recommends all travelers over the age of 6 months going or living in areas with documented measles virus circulation to be fully vaccinated with 2 doses against measles and rubella at least 2 weeks before departure. In the ongoing Brazilian outbreak, for instance, infants between 6 to 11 months represented 17% of the total cases. For this reason, they started vaccinating children aged 6 to 11 months in 2014 as a 0 dose. And these children continue with routine vaccination for the first and second dose in the routine program. For ensuring the quality of surveillance, we need to strengthen national and subnational capacity for data analysis. The following maps highlighted the lack of homogeneity in achieving the rate of measles rubella suspected cases by the subnational level in 2013 and in 2014. Subnational level is colored in green when has accomplished at least 2 suspected cases by 100,000 population. Yellow, when this rate is between 1 to 1.99, and in red when the rate is under 1. For overcoming immunity gaps in children, in 2013, the Technical Advisory Group for EPI recommended giving DTP4 and MMR second dose simultaneously. This chart shows the MMR second dose and DTP4 dose reported coverage in 7 selected countries by 2013. All of them had more than 80% with MMR first dose, but they didn't have good coverage with MMR second dose, at least at the same level of DTP4. If we could give this MMR second dose sooner, we could protect more children by interrupting measles virus transmission and avoiding complication at early ages. Finally, the follow-up mask campaign is the best supplementary strategy that we have in Latin American and Caribbean countries for maintaining measles and rubella elimination by ensuring a second vaccination opportunity. By 2015, 3 follow-up campaigns are planned for the Americas: Dominican Republic, Colombia, and Chile. Just as a background information, between 2009 and 2014, more than 60 million children under 5 years of age have been vaccinated against measles and rubella in follow-up campaigns, and more than 250 million adolescents and adults in speed-up mask campaigns. In conclusion, our challenges to sustain the gains are to increase the quality of measles rubella surveillance indicators for a rapid response to imported measles and rubella cases, to increase the data analysis and decision-making at the local level for strengthening measles and rubella surveillance, to increase the MMR first dose and MMR second dose vaccination coverage in the routine program, to support countries to ensure the high-quality follow-up campaigns to reach at least 95% of coverage at the subnational level, and finally, to declare the measles elimination in the Americas by 2016. Thank you. So I would like to introduce the next speaker, Dr. Peter Strabel, who is the Measles Program Director in the Expanded Program of Immunization of WHO in Geneva.
Thank you, Dr. Pastor, and good afternoon. In the first presentation by Jim Goodson, we saw that the 2015 global measles mortality reduction target will not be met on time, and only one of the 6 WHO regions, that's the region of the Americas, is on track to achieving and maintaining measles elimination. In this presentation, I'll address 3 questions. What are the strategies for achieving elimination of measles? Why have recent outbreaks occurred, slowing progress, and how can progress be accelerated? There are 5 key strategies for achieving the elimination of measles and rubella. These are laid out in the Global Measles and Rubella Strategic Plan. The strategies are first, to achieve and maintain high population immunity through vaccination with 2 doses of measles and rubella-containing vaccines. Second, conduct effective disease surveillance and program monitoring. Third, develop outbreak preparedness, response, and implement case management. Fourth, communicate clearly to build public confidence and demand for immunization. And fifthly, perform research and development to improve program efficiency. Now, measles outbreaks are affecting every continent and slowing progress towards the regional elimination goals. This map shows the reported incidence rate per 1 million population for the 12-month period from April 2014 to March 2015. As the incidence increases, the shading progresses from light to dark. So, for example, countries shaded in dark red have the highest incidence of measles of over 50 cases per million. An analysis of surveillance data and data from outbreak investigations shows that the majority of confirmed measles cases are either completely unvaccinated or not fully vaccinated, that is, received only 1 dose. For example, in the Western Pacific region over the past 12 months, 98% of over 16,000 measles cases had received less than 2 doses of measles vaccine. In the Eastern Mediterranean region over the same period, 83% of over 7,000 measles cases had received less than two doses. Looking at confirmed measles cases in Nigeria since the start of this year, among 1,350 cases, 78% were unvaccinated. And in the US, among the 159 confirmed measles cases in 2015, 82% were unvaccinated. Thus, the major cause for lack of progress towards regional measles elimination goals is failure to vaccinate. That's the inability of the immunization program to reach all children with 2 doses of measles vaccine. Now, the largest source of susceptible children fueling measles outbreaks are infants who missed their first dose of measles-containing vaccine, or MCV1. This pie chart shows that in 2013, there were 21 million infants who missed MCV1, and that over 60% of these children are born in 6 large countries with weak immunization programs. That's India, Nigeria, Ethiopia, Indonesia, Pakistan, and the Democratic Republic of Congo. The Global Routine Immunization Strategies and Practices, or GRISP, is being developed by immunization partners to address the problem of persistent low immunization coverage. This document calls for a coordinated investment in the 8 core functions of a strong national immunization program. These are centered around a dedicated national immunization team and include a regular planning cycle, timely flow of funds down to the local level, a sufficient number of trained vaccinators, a secure vaccine supply, accurate coverage monitoring and disease surveillance systems, a vaccination schedule for all age groups, importantly, community involvement to build public trust, and finally, special strategies for the hard to reach. The 2014 report of the Global Vaccine Action Plan made the recommendation that all regions and countries establish verification commissions to scrutinize and monitor progress towards elimination targets. This table shows the scorecard on progress towards regional measles elimination goals. The Americas is clearly out front, with all but one, that's 97% of countries in this region having achieved elimination of measles. Europe is next with 41%, followed by the Western Pacific with 22% of their countries having achieved elimination. The African, Eastern Mediterranean, and Southeast Asian regions and their member countries have still to establish their verification mechanisms. As we saw in the previous presentation, new technologies and innovation are critical to keep the program moving. The most common rate-limiting step in conducting measles vaccination campaigns is the number of qualified vaccinators. So if vaccination could be made easier, for example, like applying a Band-Aid to the skin, it could be delivered by volunteers. Research is ongoing at CDC and Georgia Tech to develop an intradermal patch, and this slide shows the advantages of such an approach, which would not only be able to be given by volunteers, but also get rid of bulky syringes, the need for vaccine reconstitution before administration, and the risk of needle stick injury, which requires careful disposal of sharps. To make the program more effective, the Measles and Rubella Initiative has put in place a management team with working groups shown on the right to directly support implementation in the countries of the 5 key strategies to achieve elimination of measles that I described earlier. Over the past 5 years, funding for measles and rubella elimination has been overshadowed by polio eradication and new vaccine introduction. This bar chart shows the situation has improved, with Gavi, the Global Vaccine Alliance, committing approximately half of the estimated $1.4 billion of external funding required for disease control activities from 2015 to 2020. Taking into account pledges from regular donors to the Measles and Rubella Initiative, there's a critical shortfall of $369 million needed for vaccination campaigns that aim to reach children missed by routine immunization. In summary, there are 5 well-recognized and clear strategies for the elimination of measles. The cause of recent outbreaks of measles is failure to fully implement these strategies. So to accelerate progress, we need to increase investment in national immunization and disease surveillance programs, use verification commissions to independently monitor progress, and pursue game-changing solutions such as the microneedle patch vaccination. We need effective program management, as is now being implemented through the working groups of the Measles and Rubella Initiative. And finally, we need more active resource mobilization that gets the message out that measles vaccine and vaccination is one of the best buys in public health. So in the 4 presentations made this afternoon, the following main points are highlighted for regaining momentum in our fight against measles. Measles is a severe disease that's fully preventable through vaccination. Experience in the Americas has shown that with use of combined vaccines, it's possible to eliminate not only measles, but also rubella. In fact, in April of this year, an independent expert committee reviewed data from each country in the Americas and confirmed that rubella has been eliminated. The Global Laboratory Network is a valuable asset, enabling accurate diagnosis and virus tracking. In the past 5 years, global progress has slowed, and in some regions, gains have been lost because of failure to deliver 2 doses of measles vaccine to all children. Finally, our best defense against measles is a strong offense. To get back on the attack against measles, we need to raise visibility, commitment, and investment towards the global elimination of measles. Thank you.
Thank you. So I think we have about 10 minutes for some questions, any from the audience, and also we're on social media, so if we have some from social media. Susan?
From a viewer in Nigeria, it baffles me that after immunizing 10 children for measles, about 2 to 3 of them still come down with measles infection. Please, what could be responsible for this relapse?
Could you just repeat the beginning of that?
Yes, it baffles me that after immunizing 10 children for measles, about 2 to 3 of them still come down with a measles infection. What could be responsible for this relapse?
Well, if I understand correctly, the question is about vaccinated children that still get measles. And so we know that the vaccine effectiveness for the first dose it's dependent on the age of administration, but when it's given at 9 months of age, it's 85%. So that means that 15% of the children vaccinated at age 9 months are still susceptible for measles, and so will likely still get measles. But we also know that 2 doses of measles vaccine, which is recommended when the second dose is given after the first year or after 12 months of age, 2 doses protects nearly everyone, all children. So if you can get 2 doses to all children, you're not going to see many vaccine failures. Question in the room? Yes.
Thank you. Regarding the microneedle patches, do those require cold chain management, or are they taken outside the cold chain?
Thanks very much. And Paul, do you want to respond to that?
The plan is to develop a patch that would be thermostable, so it would need limited cold chain, we think, and we're trying to eliminate the need for the cold chain altogether, but at least reduce it as much as possible.
Yes, Laura?
Thank you. I have a question about areas where measles vaccine is accessible, and yet there's still a lot of disease. And I'm wondering about what do you think are the most important policies to reduce the spread of disease in these areas? And I'm particularly wondering about, for example, school requirements or incentives for being up to date, like we see in countries like Australia, healthcare requirement policies or mandates. If you could comment on what you think are the most important ones, that would be very helpful. Thank you.
Yeah, thanks, Laura. I think you've actually touched on a number of the policies that actually are effective in this sort of setting. So what you're describing are settings really where vaccine is available, healthcare workers are available. The problem is reluctance or hesitancy on the part of the parents to actually have the child vaccinated. And I think here there are a number of different reasons as to why a person or parent may be hesitant, but I think definitely working through providers to make sure that the providers are giving a strong positive message about the benefits of vaccination is a critical strategy. And we definitely see settings, and even within countries where the providers are pro-vaccination, coverage rates are high. I think you mentioned other important ones such as school-based or school entry checking and vaccination. This was very well done recently in the UK, where they did a catch-up program reviewing records of all children at school and actually caught up children who'd either not been vaccinated or not fully vaccinated as a result of the Wakefield issue. So that birth cohort of 10 to 14-year-olds was actually caught up through a school-based vaccination program. Healthcare workers, I think, as Dr. Frieden mentioned in his opening remarks, are another important group. And this is, again, where I think we can lead by showing the example that we really, healthcare workers, need to ensure that they're immune to both measles and rubella. So I think these are some of the strategies.
Susan?
From our MSF colleagues in Paris, do you believe that the measles aerosol project will eventually be able to deliver an aerosol vaccine that is not inferior to the current subcutaneous one? Do you think that the aerosol formulation will have a better stability profile and could potentially be used in a controlled temperature change setting?
Thank you for the question. I can comment, and then Paul might want to follow up. But the aerosolized project looked like it was going to be the next alternative method for delivery of vaccine. There was a study published that showed that it did not pass the non-inferiority test, although there's still work going on to develop that vaccine, as we understand. So it's not completely a finished product. And just to say that the microneedle patch is looking to be a little bit more advantageous in many aspects. And so there's investment, and we're encouraging investment in developing that alternative method as well. And there are a number of different groups that are working on developing a microneedle patch. Paul, did you want to follow up? Okay. Yes, please, Rana.
Yeah, Rana Haji, NCRD. Thank you all. Wonderful presentation. Just, I was wondering when you were presenting the barriers for the elimination, a lot of it is related to the failure of getting 2 doses, and a lot of it is due to the instability in various regions. And Dr. Frieden mentioned at the beginning how in West Africa we're starting to see outbreaks of measles. Do you have, it came up multiple times in other emergencies to do additional campaigns for measles, but are there any policy and guidelines about measles vaccinations? I mean, do we have to wait until there's an outbreak to start vaccinating? Or, but also, this has been a lot on our mind lately with all the global health security planning we've been doing here, and this is the only immunizations indicator, actually, we have for GHS, is measles.
Thanks, Rana. No, it's a great point. In fact, there are standard guidelines, the so-called SPHERE guidelines, which actually recommend in any humanitarian crisis to actually do a preventive vaccination campaign. The standard is actually 6 months to 15 years of age if you don't know vaccination status in that setting. So this is pretty much standard practice, and I think where this has been done, I think most recently is in the Nepal earthquake, where in fact they'd recently, just two years before, done a measles rubella catch-up campaign with high coverage, but still went to the 14 most earthquake-impacted districts and did an under 5 vaccination. So I think this kind of preventive campaign really plays a big role, and so we're just not seeing the kind of mortality we used to see back in the 80s in these settings.
You also brought up the situation in West Africa, so I just also wanted to say that for the Ebola crisis, the polio eradication infrastructure that's been built up over time has really proved to be helpful in containing Ebola, especially in Nigeria in particular. There was a great example of the use of that infrastructure. And so as polio is ending, I think it's important that we look for ways to continue the capacity of elimination, eradication type infrastructure that can deal with not only the targeted disease, but emerging pathogens if they do come about.
I mean, just maybe a quick comment. It's almost like a marker, measles, for weak health systems. And, you know, I think if we could use the measles opportunity to also strengthen, you know, systems for all immunizations. I mean, in addition to the short-term emergencies, there are some longer-term emergencies, like the EMRO region, where you have people living in camps for years now. And, you know, I knew about the guidelines, but, you know, sometimes for chronic emergencies, this is more difficult to manage.
Rana, just to say, I think you make a great point that measles is a great marker of inequity and groups that are marginalized or don't have access to vaccination get hit disproportionately, and also their mortality or the severity of the disease is disproportionate because there's often underlying vitamin A deficiency or other reasons to increase the case fatality ratio.
I just want to take the opportunity to make the point, too, that measles is really the epitome of inequity in global health, and that in the pre-vaccine era, everybody got measles. We all got measles. It didn't matter who you were, but by age 15, 90% of us all had measles. Today, that's not the case. With this stagnating measles vaccination coverage around the world, what we're seeing is that those that don't have good access to immunization services or good health care are the ones that are most impacted. The outbreaks are happening there. The burden of disease is happening there. So really, if we're going to go after health equity, I think measles really should be looked at carefully. Rebecca?
Thank you. Very excellent presentations. Three of you spoke about the need for sustained and continued investments. So I have a question for Dr. Pastor. How are countries in the region of the Americas able to sustain their current efforts, both investment-wise and also in terms of the disease control? Thank you.
Fortunately, Latin American and Caribbean countries are autosustainable. So the EPI program has their own budget, so they are buying the supplies, the vaccine, they pay for the human resources, field activities. So they are also paying for the lab supplies, and everything related with the operational activities are also financed by them. So I think that for the Latin American countries and Caribbean countries, the most important thing is to continue investing in financial resources, but also to have a workforce very well trained at the local level, because the lessons learned say that if you don't invest in the local level, in the training of the human resources, you are going to have problems, not just for vaccination activities, but also for surveillance activities. And this is the main point in the post-elimination era in the Americas, that we need to be very careful about the imported cases. Imported cases are going to be contained and controlled with high vaccination coverage, but also with a very good quality surveillance system. So in this, the countries are investing efforts. They are going, in all the years, they made a plan of actions every single January at the beginning of the year, putting in the plan of action everything that they need for the governments to be allocated in terms of financial resources. Of course, there's nothing perfect. I think that the budget needs to be improved in terms of more financial resources. But at least at this time, we think that this has been a good point, an advantage of the region, of our region countries.
Yeah, just to add, of course, until measles is eliminated around the world, there's going to be a constant cost and need to maintain vigilance in countries that haven't eliminated. I'm going to give the last question to Bob Chen. I see he's been waiting patiently.
Thank you. So one brief comment and then a question. So to illustrate how explosive and infectious measles is, I investigated an outbreak in a high school of 1,500 kids. Index case, first generation, 60 kids. After that, 0 cases. It meant that the index case, while she was in school for 2 days, exhausted every single susceptible in a high school of 1,500. So that shows that. The need for sustainability comes in part from the challenge from that relatively lower, or let me say kind of that primary vaccine failure rate of kind of 5 to 10% that the first questioner asked about. And that requires us to do a second round of vaccination of everybody just to catch those 5 to 10%. So it's a relatively expensive and wasteful process. Is there any sense from our understanding of the biology of that primary vaccine failure where the microneedle approach will allow us to do better than that 5 to 10% primary vaccine failure rate and thereby eliminate that need for a second dose?
Thank you for the question. First, just to say that we know measles vaccine is one of the best buys out there, and it's $1 a dose, which is much less expensive than some of the other vaccines. But Paul, do you want to comment on the microneedle potential?
Well, it's a great question, Bob. I think it's certainly something that we need to investigate. I don't think we're that far along with our microneedle studies. We've got some work going in non-human primates right now, and we could attempt to address some of those questions, but some of them we're going to have to wait till we get to clinical trials. Though there is some suggestion, if you look at the literature on intradermal vaccination and the microneedle literature in particular, that going in through the skin might be a more efficient route because you have the potential to engage more antigen-presenting cells, dendritic cells, and things like that in the skin. So some other vaccines that have gone in through that route have given better responses or allowed dose sparing. Those, I think, were mostly inactivated vaccines, and so for MR vaccine, we're looking at 2 live attenuated vaccines. So I think these are certainly things we're going to look at, but it's a little bit too early to see. So.
I wonder if I can just make one more point, Bob. I think, it would be great if the immune response was somehow stronger, but I think the real benefit we see is from the program side, that we could use volunteers to go on a house-to-house basis and really reach that 5th child that we continuously missed. So I think that's really the value that we see from the program end.
No, definitely, and being able to avoid those program costs for the second dose, albeit the vaccine is relatively cheap, it will definitely save us. Thank you.
And thank you very much for joining us, and thank you to our speakers. Please join us next month.